everyone. Welcome, welcome. We are going to start in just a second. We'll wait for a few more people to join the room. Great. All right, well, welcome everyone to the webinar. Thank you so much for joining us today. Good evening, good morning, good afternoon. We are here today co-hosting this webinar by Hep United and the World Hepatitis Alliance. My name is Kate Morales. I'm the Deputy Director of Public Health at the Hepatitis B Foundation and Director of Hep United. So before we get started, wanted to share how you can participate in today's webinar. All attendees are on mute. Feel free to use the chat window to say hello, introduce yourself. Feel free to drop a chat now. Let us know where you're coming from. Where in the world are you? Tell us what country you're located, or city or state if you're in the US. And then finally, if you have any questions, please feel free to share your question in the question box, and we will take them at any time as they come in. We'll collect them, and then we're going to have a moderated panel and audience Q&A after the conclusion of all the presentations. And this session is being recorded, so we'll be sure to share out the recording as well as a copy of the presentation slides with everyone after the webinar. Great. So as I mentioned, we're co-hosting this webinar with the World Hepatitis Alliance. Hep United is a national coalition based in the United States. We're dedicated to reducing the health disparities associated with hepatitis B. We have about over 50 coalition partners around the US working to improve awareness, screening, vaccination, and linkage to care in communities that are highly impacted by hepatitis B. We serve as a forum for sharing information and best practices and improving the capacity to improve hepatitis B awareness and testing in highly affected communities. So if you're in the US and you're interested in becoming a partner of Hep United, please feel free to reach out. And now I'm going to turn it over to Danjuma Ada, who is the incoming new president of the World Hepatitis Alliance, to say a few words on behalf of WHA.
Hi, everyone. Good morning, good afternoon, and good evening. I am Danjuma Ada. I am the president of the World Hepatitis Alliance. And the World Hepatitis Alliance is excited to be part of this meeting, co-hosting this webinar with Hep United. And I'm glad to say that I'm taking over, assuming the duty from Sue, who is based in the United States. So the World Hepatitis Alliance is an international network of organizations working in over 100 countries towards the goal of eliminating hepatitis by 2030. Our network comprises of civil society and community groups. I dare say that we are the face of viral hepatitis. We lead the fight against viral hepatitis through advocacy, capacity building, and awareness raising. We are led and governed by people with lived experience of hepatitis and ensure that people with lived experience of hepatitis are at the heart of everything we do. So we're excited to be part of this meeting, and I just hope that every one of us will sit back to learn and to get the best from this meeting. Thank you so much, and do enjoy the meeting.
Thank you so much, Danjuma. Great. So I'm going to go ahead and introduce our wonderful panel of speakers today. We are going to start off with Dr. Robert Wong. Dr. Wong is a clinical associate professor of medicine in the Division of Gastroenterology and Hepatology at Stanford University School of Medicine in California in the US. He's also a staff physician in the gastroenterology and hepatology section at Veterans Affairs Palo Alto Healthcare System. Dr. Wong's clinical interests include management of patients with complex liver diseases, including viral hepatitis, liver cancer, and non-alcoholic fatty liver disease. And his research focuses on epidemiology, and outcomes in patients with chronic liver diseases and healthcare disparities among underserved minority populations. So Dr. Wong is going to kick us off with some epidemiology work that he has done recently. I'm going to go ahead and introduce all the other panelists to save us some time. After Dr. Wong's presentation, that focuses on the US prevalence, we're going to go with global, and Dr. Fumi lacy will go next, and she is the hepatitis team lead at the World Health Organization, Department of HIV, Hepatitis, and STIs, based in Geneva. She was previously a regional advisor for viral hepatitis in the WHO Afro office, where she provided country support and oversaw the coalition of hepatitis strategic information and surveillance data in the Africa region. And after Dr. lacy speaks, we'll have Dr. Sue Wong, who is an internal medicine physician and the medical director of viral hepatitis programs at the Center for Asian Health at St. Barnabas Medical Center in New Jersey in the US. She was also the past president of the World Hepatitis Alliance, and she is also living with hepatitis B. Her work with WHA was focused on amplifying the voice of people living with hepatitis and the affected communities in order to achieve health equity on the road to hepatitis elimination. And then finally, we will have Chris Munoz joining our panel from Asia. Chris is the current advisor and past president of the Yellow Warriors Society in the Philippines. He has been a patient advocate for over 9 years, and he's also the vice president of the Philippine Alliance of Patient Organizations. So thank you to all our panelists for being here today. We are excited to hear from all of you. And then I'm going to go ahead and have Dr. Wong kick us off.
I'm going to screen share.
Oh, okay. You have the remote if you'd like to. Okay.
Make sure this is the right one. Do you guys see the correct slide?
Yes.
Perfect. Well, thanks so much. Thanks, Kate, and thanks Hepi Foundation, World Hepatitis Alliance, and Hepi United for inviting me to present in today's panel. It's so exciting to be part of this panel of people across the world that are very engaged and excited about working to aim for elimination of hepatitis B. So today I'm going to talk about some updates in the prevalence of chronic Hep B with a focus on the US. And this is our objectives. So the background, many of you know, majority of individuals with Hep B in the US are foreign-born. And existing studies that examine the prevalence of chronic hepatitis B have used large data sets, surveillance data, and we know that these have limitations in accuracy because they may not accurately capture populations that are at high risk for Hep B, including ethnic minorities and vulnerable populations. Underdiagnosis and underreporting also due to suboptimal screening and linkage to care continue to present challenges to understanding the true epidemiology of chronic hepatitis B. My goal today is to review a recent paper we published just a few months ago that provided an updated estimate of chronic Hep B in the US. And we had the privilege of working with a range of experts in the field, as you can see here. And I think you'll be very excited about some of the data that we have to share. Just going to briefly go over our methods. It was a systematic review and meta-analyses of country and region-specific chronic Hep B prevalence, focusing on large population-based studies. We used those studies and we linked it with country-specific prevalence with the US Census Bureau to estimate country-specific and year-specific prevalence to the US based on predicted immigration patterns. We calculated the prevalence for each country using random effects meta-analyses, and then we estimated the number of non-US born individuals with hepatitis B in the US in 2018 using these methods by extrapolating from their original country-specific prevalences. And then we added that to existing estimates of US born chronic Hep B to give a bigger picture of what the total burden of chronic Hep B is in the US. So this is our search process. It was pretty extensive, as you can see. We found a total of 2,800 surveys or studies that included 112 million subjects. After inclusion and exclusion evaluation, we identified 450 surveys from 65 countries. 2,343 were surveys of populations living in the country of origin, and 457 were surveys from immigrants. And you can see the numbers there. We also looked at decade from which the study was done because we extrapolated that using the decade of publication census data and tried to match that as best we can with immigration patterns. Finally, 27% of the total population we looked at were male, 58% were female, and then about 15% of the studies that we included didn't include data on sex or gender. So this is the big picture that I wanted to focus most of the time on. Let me orient you a little bit. On the left side of the graph, this was our estimate of the number of foreign-born individuals in the US that immigrated from each country. So for example, how do we interpret this? In 2018, the number here on the side, we estimated about 14.7 million individuals in the US were from the Asia region. 24.4 million were from the Americas, and so on. So the left side is the overall population and the country from which they came from. The right side of the graph is where we look at the chronic Hep B population. So for example, here, 869,000 individuals with chronic hepatitis B in the US were from Asia. Second, 274,000 chronic Hep B individuals were from the Americas. So what we can see here is when we look at immigration patterns overall, the majority were from Asia and the Americas. But when we look at the contribution and demographic makeup of the chronic Hep B population, the majority were from Asia, and actually Americas and African region, with a smaller contribution from Oceania and Europe. So this gives us a big picture of what the demographics of the US chronic hepatitis B population look like. Then we did some, not going to go into this in too much detail, but to give you a sense of the rigor that we performed, we did a variety of different sensitivity analyses. So original estimate was 1.47 million individuals with chronic hepatitis B that were foreign-born. Then we did different sensitivity analyses, adjusting by decade of entry, adjusting by sex. We looked at different subsegments of surveys to try to get a better sense of quality of studies. And overall, you can see that the estimates are fairly similar and around the same range. When we compared it to existing studies, you can see here a recent study from NHANES, a couple actually, gives pretty wide-ranging estimates. And then some previous studies, including one that we did about 10 years ago, it gives a different range of estimates. So really what we estimated is compared to our study in 2009 to 2018, there in fact was an increase in the prevalence of chronic hepatitis B in the US. Majority of this increase was due to individuals from Asia, as you can see in this light blue bar on the bottom, and from the Americas. And the top kind of darker, I guess it's not really dark, but the top section of the bar here represents the US or domestic born individuals. And for the most part, you can see that hasn't really changed. But definitely the contribution of individuals from other countries has contributed to an increase in Hep B prevalence. We've actually recently are in the process of updating this to 2019, and we've seen an additional 13% increase in the prevalence of chronic hepatitis B overall. So what are the take-home points from our study? We did a comprehensive meta-analysis, and we included a broad range of studies that spans 40 years that incorporated changes in immigration patterns that affect US populations utilizing country-specific chronic hepatitis B prevalence. And we observed that the number of foreign-born adults with chronic hepatitis B living in the US was about 1.47 million, but as high as 1.73 million based on our confidence interval. This represented an increase from about 11% based on our previous study in 2009 that estimated this at 1.3. And as I mentioned, we're recently refining the study, and we've seen an additional increase of about 10 to 13% in 2019. When we combine that with estimates of US prevalence based on existing studies, which estimate about 422,000 US-born individuals with chronic hep B, our total estimate for chronic hep B prevalence in the US in 2018 was about 1.89 million, and that was as high as 2.4 million when we include the range of error. And so that was our most recent study, hopefully providing a better estimate to guide epidemiology and public health and resource planning for the US. And with that, any questions? I think we have a panel later, and here's my email if anyone is interested afterwards as well. And great, so I'll stop share and turn it back to Kate.
Thank you so much, Dr. Wong. That is, we're looking forward to discussing more about what's driving it, immigration, and as many people may not know, the surveillance infrastructure in the US is not funded well, and so we do definitely need great modeling to show kind of the intersections of what's causing the increases in hepatitis B in the US. So now I'm going to go ahead and turn it over to Dr. Fumi Lacy from the World Health Organization to share with us what's going on globally.
Thank you. Can you see my screen?
Yes.
Okay. Hello, everybody. Good morning, good afternoon, good evening. My name is Dr. Fumi Lacy, and I am delighted to be here and pleased to see many friends and colleagues on this platform. And I would begin by thanking Hepatitis B United and World Hepatitis Alliance for organizing this webinar and inviting the WHO Global Hepatitis team to this very, very important conversation. And I will be talking on the global epidemiology of hepatitis B. And I acknowledge my extensive clinical experience as a hepatologist of managing hepatitis B liver disease and cancer at the clinical bedside for over 2 decades, and now working with regions and countries throughout the world for hepatitis elimination. And just a brief outline, I know I have 8 minutes and I will try to go quickly through my presentation. So viral hepatitis B, we do know it's a high burden disease, and we know it's a small virus. We know about the cccDNA that is responsible for viral persistence. And we do know that the outcome of infection is variable, ranging from fibrosis to liver disease, liver cancer. And we do know that liver cancer can occur in hepatitis B without going through the phase of fibrosis. We know that there are different routes of transmission depending on the endemicity of hepatitis in the country. And we know that there's vaccination, screening, and treatment with oral therapy, which is usually lifelong. I thought to introduce again this global hepatitis agenda for some of our participants who have not seen this ever. We know that WHO with the World Health Assembly set ambitious global goals of elimination of viral hepatitis as a public health threat. And this is defined, as you see on the screen, by reduction of 90% in new infections and 65% in deaths by the year 2030. Now, 6 key interventions have been modeled to reach elimination if scaled up. And this is shown on the right side of the screen. This is interesting because now we know that worldwide, there are nearly 300 million people with chronic hepatitis B infection. And Dr. Wong was quite correct. 70% of global infections occur in the WHO WIPRO region and the Afro region. Therefore, the Afro and Western Pacific have the highest prevalence and the largest number of people. This slide shows the endemicity, and in highly endemic areas, infection is primarily perinatally or in early childhood. In areas of intermediate endemicity, it occurs in all ages, and in the US, where there is low hepatitis B seroprevalence in the general population, most infections occur in adults, especially among people belonging to a defined risk group, some of which Dr. Wong has alluded to. It's interesting to see a partner put up the top 20 countries that have hepatitis B burden, including China, India, Nigeria, Indonesia, Philippines, as you can see on that list. So in 2015, the WHO reported an estimated 257 million hepatitis B infections. And in 2019, this number was reported as 296 million. So it is evident that between 2015 and 2019, there's an increase in the burden of viral hepatitis. Most of this burden is seen in Africa and in Southeast Asia. It's well noted that in the Americas, the burden of viral hepatitis reduced, and so the same we see in Europe. So we look at the 2021 WHO progress report to highlight the unmet critical need for hepatitis B care. And what we are showing here is the new infections and the deaths caused by viral hepatitis, both B and C. In 2019, 3 million new infections and 1.1 million deaths were recorded. And one of the major achievements was the reduction of hepatitis B prevalence globally under 5, reaching all the targets. On the right, it shows clearly that hepatitis B is a bigger source of liver cancer than hepatitis C. And this is what I talked about the impact of vaccination and reduction in prevalence in children under 5 years old. However, in some parts of the world, the prevalence of hepatitis B in children remain above 1%. And globally, there are about 6.4 million children less than 5 years old who have chronic hepatitis B infection. The report also shows major gaps in testing and treatment towards public health elimination. And just to mention the global, it's estimated that only 10% of the nearly 300 million people have been diagnosed, and only 2% have had access to care. So there's a huge testing and treatment gap. This is a particularly important paper, which I will not go into detail, but it suggests that over 26 million people have cirrhosis due to hepatitis B and are definitely in urgent need for antiviral therapy and identification. So it makes me remember the missing millions. Now, this is an emergent missing 26 million people with cirrhosis. And this slide just shows the impact of hepatitis C public health approach in many countries. And we need to see more of this impact occurring in the hepatitis B field. I'm going to talk briefly now about the new WHO strategy, which highlights the visions and goals for 2022 to 2030. And there are 5 main strategic directions, as you can see. And the first one is about people-centered services. And the second is about optimizing health systems, health sectors, and partnerships for impact. So we're talking more about integrated services, integrated care, integrated B and C. And the prototype of this is really triple elimination of hepatitis B, HIV, and syphilis. And all of this could operate on a similar platform and will be needed to scale up to achieve the elimination by 2030. The third direction is about the use of data, very important because many countries do not have the system to report hepatitis B and C, surveillance and deaths and treatment and testing. Again, the community is key to reaching elimination and building a community of hepatitis B that speak out will have an impact on advancing the progress. And of course, innovations for impact and leadership. I put here on the screen 8 key strategic shifts that has been proposed to drive the hepatitis response over the next 8 to 10 years to 2030. Now, because of time, I will not read through the whole list, but number 1 is awareness, and of course, resources and universal access to hepatitis B birth dose and investment in primary prevention. We're looking at simple, decentralized services, community, and innovations, including hepatitis B cure and better point of care technologies. So WHO has also highlighted and developed this interim guidance for validation. And one of the key takeaways and important thing here is that now we have the end game, we have a benchmark using absolute numbers to measure country progress and to motivate countries to reach elimination of viral hepatitis B and C. WHO has a lot of products that will guide this progress, including guidelines for treatment, for testing, for community engagement. And coming soon is the update of the hepatitis B treatment guidelines that will expand the treatment and the testing criteria. So in summary, the key messages are on the screen, a huge burden with major gaps. So we have the strategy, we have the tools to make it a reality, and we probably need to build back better, differently to enhance the opportunities that have opened for treatment, and of course, political commitment and collective effort. And on that note, I say thank you very much for your time, and I hand over to the organizers. Thank you, and over.
Thank you so much, Fumi. That was really exciting to hear, and that the World Health Organization has definitely developed some really wonderful resources, and clearly viral hepatitis B is a priority for the WHO. I'm going to go now to Dr. Sue Wong. Sue, if you want to share your screen and your slides, we'd love to hear from you as a person with lived experience, your reflections on Dr. Wong's and Fumi's presentation.
Of course, I'm muted. Sorry about that. All right. Thanks, Kate, and thank you, Fumi and Robert, for your presentations. Those were really good, and I think will stimulate a lot of thought and discussion for the audience. So I want to now talk about the response and really the role of civil society and our communities in driving elimination. So I just want to start with this fundamental tenet, which it's great to hear WHO saying similar messaging, that elimination will not be achieved without involving people who are affected by viral hepatitis. And this is a critical key and really a game changer in making sure we get to elimination to the people who need it most. So just a little background about the World Hepatitis Alliance. We are a nonprofit, an NGO that is patient-led or led by people living with viral hepatitis. Our mission is to harness the power of people living with viral hepatitis to achieve its elimination. And I just love this diagram because it just really talks about how important it is for us to activate the power of the millions. So if we think about it as, we always talk about we don't have a lot of resources in hepatitis B or C, but we sure do have a lot of people living with it, as Fumi had just mentioned. And so if we're able to identify or diagnose and then energize these millions of people, then we can actually have a force of people and communities that are increasing awareness, demanding access, driving advocacy, which we've seen done very effectively with the HIV population. They can partner with scientists, researchers, and policymakers and combat stigma and discrimination, which is really important, and also ultimately improve program delivery. Fumi also mentioned Find the Missing Millions, and this is really one of the first steps. We still need to really identify the many people living with viral hepatitis. As she mentioned, only 10% are currently identified. I just want to read this. We have a campaign called Find the Missing Millions, and I just love, what this message is, that people living with viral hepatitis and the affected community should be at the heart of every effort to eliminate viral hepatitis. Aside from fulfilling the need for trusted entities that consistently disseminate reliable information, civil society organizations bring fundamentally important perspectives and experiences which greatly enhance the effectiveness of strategies and programs. I just think that's important to remember, and just for you all to realize, especially I see a lot of community members here, how important your work is and everything. So Fumi had mentioned the interim guidance for country validation of viral hepatitis elimination, which came out last year. And she talked about some of the programmatic targets and also talked about how important community engagement is. And I just want to highlight within this document where that is, because I think it's important as community members, we realize this is what WHO sets as being part of the national strategy. And those of us in the community need to be aware of this so we can hold our governments accountable. So here in the section 644, it talks about how the meaningful participation of people living with hepatitis B and C and their families and communities is important to determine and develop national and subnational policy for affected communities and should be actively promoted. Community engagement is also important and highly relevant for supporting and implementing service deliveries. And below there are four particular things that are what they're using to assess whether a country does have community engagement. And in the document, there's also an annex to, it's a checklist basically. So if a country is submitting a dossier to WHO showing that they believe they've eliminated Hep B or C, there's this checklist at the back for them to fill out for implementation considerations. And so you'll see at the top, there's criteria looking at, human rights, equity, and also gender equality. And then finally, there's a section on community engagement. So, and the components we have here are evidence of the affected community representatives in the National Hepatitis Task Force, national hepatitis policy documents that explicitly state the active participation of affected community in hepatitis prevention, diagnosis, and treatment services. Oh, this is on some sort of timer. Evidence of peer-led navigation in hepatitis service delivery for hard to reach rural and marginalized populations. And finally, and I think this is something we would all really appreciate, evidence of government support or funding for representative groups of the hepatitis affected community. So I think this document can be used when you are doing advocacy in country. And as we had talked about, really the first step is we need to get people identified still. Globally, only 10% have been diagnosed. And even in the US, it's still the large majority of people living with Hep B who are unaware and not in care. And when we contrast this with HIV, which has had universal screening since 2006, compared to the risk-based screening strategy, we see the stark contrast. So the light blue in the pie shows you the segment of people who are unaware and not in care. And then HIV, it's clearly the minority, whereas with the Hep B, it's unfortunately a large majority. So this is where advocacy really helps. I mean, I think we're seeing some fruits of advocacy federally in the US. Just last year, the ACIP, which makes recommendations on vaccinations that then get approved and accepted by CDC and insurance companies, did vote last year that all adults between ages 19 to 59 should be vaccinated against Hep B infection. And we're very much looking forward to CDC reviewing evidence this year that all adults be screened for Hep B infection, regardless of risk factors. So a universal screening strategy as opposed to risk-based to follow what's been done for Hep C and HIV. So we're looking forward to this. There'll be a time for open comment, and we would, encourage people to provide comment for that. And then in the US, there's been some great milestones in California state. They passed last year a requirement that all healthcare providers offer Hep B screening tests for adult patients as part of primary care services, and that it would be covered by insurance. So that was also quite an achievement. So all this to say, you know, being active regionally and nationally are really important. Hep B Foundation has done quite a bit of work with discrimination. You know, part of what we see is people are unlikely to come forward for testing if there's a sense that there could be discrimination. So a lot of the efforts legally and in policy are really important too. There have been numerous cases of Hep B infected healthcare students, professionals, and also military service members who have faced discrimination due to their hepatitis B status. And in the US, we have it's been a protected condition under the American with Disabilities Act since 2013. So it is considered illegal to discriminate. And this is something we hope that other countries will also begin to adopt. And there's a registry now for discrimination. If any of you in any country are seeing this, please, you know, please use the Hep B Foundation discrimination registry, because we want to hear about these cases. So, and all this to say that we need more awareness. Awareness is huge. I just did a podcast, and the podcast people who look at all sorts of infectious diseases were just astounded about the burden of Hep B, and yet how little it is mentioned and discussed. And it just shows you we have a lot of work to do. And so Hep B, with World Hepatitis Alliance last year, on World Hepatitis Day, we launched a new campaign called Hep Can't Wait. We want to impress the urgency of the crisis here. You know, every minute, every 30 seconds, somebody loses their life to hepatitis. And we talk about babies needing vaccines and so many populations that are really disproportionately affected. So we hope this year, which won't be till July, you guys will also join in on this awareness campaign. And this is just some really neat things that people in different countries did last year for Hep Can't Wait and World Hepatitis Day. So, you know, it's good time. You guys can start planning this year for July for some other interesting, exciting things too. And then another campaign we have is No Hep, which was launched in 2016 to follow the GHSS strategy. And it really unites people around the world for the elimination of viral hepatitis. This is like our red ribbon for viral hepatitis. And this is, there's a separate website for this. You can sign up to get announcements and infographics and different resources like this. So we had a mom's campaign this past year, really emphasizing how important it is to get birth dose to babies as soon as they're born. It's only happening in 40% of all babies born in the world today still, which is really outrageous. And so babies are being born and then getting infected with Hep B every day. We think about more than 1 million 5-year-olds currently are infected with Hep B, and this really shouldn't be the case. So this is another important movement that we're hoping to get more momentum behind. And no matter what you do, you can be a part of it. Medical professionals, we have a whole separate component of the No Hep campaign for medical professionals. And the top picture is just a picture of the No Hep village, kind of akin to the global village that's done at the AIDS meeting. We really want to celebrate the community at the scientific meetings too. And it's important for us to really integrate science and community, and we hope you will join us on that effort. So I will close with that, and back to you, Kate, for the panel.
Fantastic. Thank you so much, Sue, for sharing and your perspectives and just emphasizing how important it is to be an advocate for viral hepatitis. There were some great questions that came in and some resources that were shared that you had mentioned. So the discrimination registry, it's a global discrimination registry. Catherine dropped that link in the chat box. So we definitely want to hear from you or anyone you know that is experiencing discrimination. And then the podcast link that Sue mentioned is also available in the chat box too. And we'll be sure to send those links out along with the presentations afterwards. So I'd like to invite all our panelists to join us, but I'm first going to turn to Chris Munoz, who is with the Yellow Warrior Society in the Philippines. Chris, thank you for being here with us. We'd love to hear from you and share, if you could share more about what is going on in the Asian region or in the Philippines. How is the state of hepatitis B in Asia right now?
Well, if we're talking about the vaccination, in 2020, which the year COVID started, data in the Philippines showed that there is a drop of Hep B vaccination because of COVID-19, which is understandable. By the way, the government has been giving Hep B vaccines for free for 10 years already for newly born babies. But there's also lack of catch-up vaccination program to compensate for the downtrend. In fact, the vaccination rate is much higher in far-flung areas than in Metro Manila, which is the epicenter of the pandemic. They did catch-up vaccination in some diseases like measles, except for Hep B. And sometimes there may be lack of availability or accessibility of Hep B vaccines in some parts of the country because Philippines is an archipelago. And its administration wherein they have to schedule vaccination days or they have to get a number of babies before they administer the last 3 doses since the birth dose is given right away. There might be also lack of free testing in public health facilities so that people will be aware of their condition. Mostly the free Hep B testing is given to mothers who will give birth. And lastly, but more importantly, is the lack of education and information to people on how important for babies to get vaccinated. Since we already have a vaccination program in place, then we have to get parents who are not aware. We still have parents who are not aware of their responsibilities. We cannot put all the blame to the government if we don't do our part, and health education is really very important for people to realize that they also have a role to play. So overall, what is really sad that in spite of the vaccination program, we still see 5-year-old children getting infected, or we see above 5 years old still not yet having vaccinated for hepatitis B. Back to you, Kate.
Thank you very much. And I wanted to also ask if Danjuma, as being in the Afro region, if you also wanted to share any perspectives on hepatitis B in the region.
All right, thank you, Kate. Thank you. The presentation from Fumi has really highlighted the great challenge we have from African region. Africa is disproportionately affected by hepatitis B, and most unfortunate to say that we have unfortunately poor evidence of data to even drive advocacy, because very, very poor testing rates. And in across most African countries, we still currently have very, very low number of countries with action plans to even talk about hepatitis elimination. That is a great gap, and that leads to very poor political will and political commitment across nations and countries towards elimination of hepatitis. And I see very low testing and treatment rates. Treatment in most areas is still specialized, not decentralized to the levels of to secondary or primary levels of care. So there is very low awareness and low capacity of healthcare providers, especially at the secondary and primary levels of care, to deliver services. So in most countries, treatment and diagnosis is still out of pocket. And unfortunately, this drives many patients into catastrophic poverty because it's not covered in most cases in health insurance. And though there are pockets of a few global fund interventions, but that is for people with co-infection. So patients with mono-infections still face inequity because they don't have access to treatment, not even to talk of diagnostics. So very, very poor testing rate, very poor diagnosis, very poor treatment rates, very poor commitment in terms of government's will to even act. Looking at the birth dose vaccine, only very few countries have even started the birth dose vaccination. Of course, most of the transmission is perinatal, and also very weak healthcare systems, poor blood transfusion screenings. So there's a whole lot of things in the African region, and despite the heavy burden of Africans with hepatitis B, we have very poor leadership among African leaders to really drive elimination of hepatitis. So over for now. Thank you.
Thank you, Danjuma. Yeah, and just hearing from you and Chris, as well as Dr. Lacy and Dr. Wong and Dr. Wong, it's interesting to see all the commonalities in terms of really needing the political will of the leadership and the importance of the birth dose globally, impact on immigration and all the intersections, remembering that we are an interconnected world, and COVID is reminding us of that now more than ever. So I wanted to turn to Dr. Lacy, if you're back with us. There was a question for you as well. I wanted to share.
Yes, I am back. Yes,
great. Great.
Yes.
So, Dr. Lacy, thank you so much for your wonderful presentation. There was a question from the audience I wanted to turn to, and I also wanted to ask you separately to talk about some successful programs, maybe within your response as well. So your key shifts, there was a slide on key shifts. It's an excellent guide for us, but we'll take increased commitment and funding. Do you, and then we'll turn to other panelists, have thoughts on how we can persuade government leaders and global funders to prioritize hepatitis B elimination?
Right. Thank you very, very much. And I think I will start by saying that the spotlight is now on hepatitis B. The elimination of viral hepatitis is in its 5th year, and many programs are nascent. There is a huge lack of awareness in civil society and in governments as well. And I think one of the takeaways from a webinar like this is to raise the awareness. As you can see in my presentation, the distribution of hepatitis B is quite regional. And one of the main shifts we need to take away is there's got to be a regional approach to hepatitis B elimination. Now, for countries like sub-Saharan Africa, where there's a huge burden and where there's a huge gap in childhood vaccination, the priority for these countries may be to begin with hepatitis B birth dose or go on to what we call triple elimination. That is elimination of hepatitis B, HIV, and syphilis, using the infrastructure that is currently available for HIV to scale up the hepatitis B response. So in terms of birth dose, there are several countries who already have established a birth dose in Africa. And there are some countries that are going on a hepatitis B drive. I will talk about Africa, and what comes to mind first is a place like Uganda. In Uganda, over 40% of the population has been screened for hepatitis B, and a robust hepatitis testing program and treatment and vaccination is ongoing. Of course, so there is need for more countries to engage and upscale viral hepatitis. But I think the first thing is that we working together need to make viral hepatitis B a political priority by talking about it. Where is the community of hepatitis B? We don't get to see the community. The voice of the community needs to be heard. We're talking about grassroots, starting from the bottom, from the grassroots, and also from policy. And the community are well served to begin this revolution that calls for hepatitis B importance and care, and to make it more a public health response. I've shared with you some of what WHO is doing. And one of the things we're going to do this year is to look at the WHO hepatitis B guidelines so that we can expand the guidelines for treatment eligibility so that a lot more people can begin testing and treatment for hepatitis B. So there's a lot to do, and it has to be a multifactorial approach, a multi-sectorial approach. And all of this has been successfully done for hepatitis C response. So together we can begin to accomplish the same for hepatitis B. I will stop right now. I'll stop here. But some low-hanging fruits also are in integration, shared platforms with HIV, with other communicable diseases, universal healthcare, healthcare insurance. In many countries, healthcare insurance does not even cover hepatitis B. So that is one of the areas we need to make a change to advance the hepatitis B response. Thank you, Anu.
And sorry, I was kicked off the line. My internet went down.
No worries, we're glad to have you back, and thank you so much. Absolutely, it does take a grassroots movement. Dr. Wong, did you want to add?
Yeah, I just want to make sure everybody heard Dr. Lacy from WHO, her call to action. The community needs to rise up. Did you guys all hear that? When WHO is saying that, I think we as a community need to realize, it's time for us to step up. I mean, I just feel like we've been in this space for so many years, showing everybody the numbers, the data, and what has it done, right? Where are we? We still have such huge gaps, and it's really, I think it's time for us as a community to demand more, right? We need to get a little more upset, more angry. Our stories are really powerful. I learned so much. Dee here is on the call, Dee Lee, and he was a board member at the Alliance. And coming from the US, I had not heard such really tragic stories of people living with Hep B, and just how it's just so many awful stories of people. The careers have changed. They've aborted their children. They've been abandoned by family members and spouses because of hepatitis B, and yet it's still so silent, right? It's time for us to really show the world that this is an urgent crisis that demands attention now. And so I hope all of you really just feel that sense of urgency and are compelled to do more and to make sure our policymakers do more. So Sherry, I saw your question and I just thought, that's what we need. What is it that will get policymakers to act? That is the mystery. And I think as a community, it needs to be something that we really, force some action here. And think about more innovative ways of approaching this than what we have been doing so far. Thanks, Kate. Over back to you.
Thank you. Yes, we definitely heard from me. I wanted to get up, and she is such an inspiring speaker and motivational. Dr. Lacy, we wanted to also chat a little about the impact of COVID. There was a question in the chat box earlier, and I think Chris, you might have alluded to the impact of COVID on vaccination services. And then we want to know about how do you think all of our panelists, Dr. Wong, Dr. Lacy, and Dr. Wong, Danjuma, and Chris, how is COVID impacting viral hepatitis service, but also the prevalence? How do you see that impacting it as well? Dr. Lacy, would you like to start? And then we'll go to Dr. Robert Wong.
Yes, I will start. I think the effect of COVID has been negative on hepatitis programs generally, but I also think it has opened a lot of opportunities, and this is the time to seize the moment. So in terms of negative, first I would start with, I said many programs are nascent, right? Programs are young. The interruption of programs have set back many countries, and WHO have done some studies on the effect of COVID in different countries. And the next report is due out this week, and I would share that with you. So one, the setback to country programming. Two, the hepatitis B birth dose, which was supposed to commence pre-COVID, has been deferred and deferred and deferred, and many countries have not commenced the hepatitis B birth dose. In many countries, of course, we know the lockdowns and all of that, and the deprioritization of hepatitis programs has led to many more people missing the timing, missing their drugs, missing their doses, etc. Now let's look at the opportunities, and we learned a lot in the COVID era. One, the community. This is the first time in 100 years that the community rose up together for a pandemic. And it shows us the power of the community to make a difference. We have to wear face masks. We have to stay at home. So without the community participating in care, there will be no progress. That's number one. Number two, look at diagnostics. COVID diagnosis has been done on HIV and TB platforms. Hepatitis B and C can also be done on the same platforms. So these silos in care, we need to start breaking down silos. So integration in lab tests, in treatment services, integrations in procurements, integration in financing, all right? And of course, we need innovations, hepatitis B cure, point of care testing, et cetera, et cetera. I don't want to monopolize. I'm going to give you time. There's a lot to discuss in the opportunities from COVID, and this is the time to do so. Thank you, and over.
Thank you. Dr. Robert Wong, would you like to talk a little about the impact on prevalence?
Yeah, and I think I agree with everything Dr. Lacy mentioned. I think that COVID definitely has disrupted care across diseases, particularly liver disease and viral hepatitis. But I just want to emphasize one thing she said about trying to look for the positives and what has happened during the pandemic. And I think one thing we can take away and apply toward hepatitis B is, with the pandemic, there has been remarkable infrastructure that has developed across health systems, across public health. And I was just reading a piece from New England Journal that was published recently describing the experience at San Francisco General Hospital and how they developed a very effective infrastructure for the safety net population to distribute COVID vaccination. And with the new ACIP recommendations, this is a model that many centers and safety nets and all health systems across the country can try and adopt that model to effectively implement adult vaccinations for hepatitis B. So I think there's a lot of potential opportunities, as Dr. Lacy said, that we can learn from this pandemic and try to glean the positives and apply it toward our goals for hepatitis B.
Absolutely, thank you. Chris, would you like to share any additional perspectives in terms of the impact of COVID or the opportunities that you see?
Yeah, I think because before I talk about the vaccination, so in the Philippines has already a viral hepatitis program, but it is only it started 3 years ago, and it is only applicable in selected cities now. And when the pandemic started, those cities that were supposed to start their own programs did not push through. So that was very unfortunate. But during this 2 years, innovations were implemented, like digital consultations using Zoom, Viber, or Facebook, because the program is located in the hospital. So because of the lockdown and the high count of COVID-19, patients cannot go and get checkup. So another thing that was practiced was giving the patient 6 months supply and shipping it to them without the need of going to the health facility every month. And the implementation of telehealth for patient support, informing them of which hospital has vacancy and giving them medical guidelines. I think throughout this pandemic, those cities who had their own program, with the help of the civil society and doctors, we continued our collaboration throughout the 2 years, and to ensure that patients will still have access to health facilities. So having a health program is not really the final solution. It is only the half of the success will lie on the patients to be able to get themselves into the health program. And that is our role as civil society to play to bridge the gap between patients and the health and the Department of Health. Back to you.
Great, thank you so much, Chris. So we have reached the top of our hour. It has flown by. We've had a wonderful conversation and excellent presentations. I think that, the theme that I heard the most is we need to become activated. We heard that loud and clear, and I hope that everyone in the audience, share this with your networks, your colleagues, your family members, that we need more voices, especially for hepatitis B, in order to reach our elimination goals globally. We need to work together. So thank you so much to everyone for taking the time to be with us today. Thank you so much to our panelists. I'd like to turn it over to Danjuma for some closing remarks before we end.
Oh, thank you so much, Kate. And indeed, it's been a very interesting 1 hour. listening to the panel of the experts from Dr. Fumi from WHO. I love when Dr. Fumi speaks with the public health approach with a passion. You can see the passion in her to really motivate us, the community groups, to do more. And I'm excited that just like Sue rightly mentioned, she has really placed it out on the table for us that it is time for us to take action. It's time for us as a community to have this voice, a united front to really speak up for hepatitis, most especially for hepatitis B. And I would say this with all due sense of responsibility, that while not overlooking the successes in hepatitis C, we need to shed more light on hepatitis B. I know what it means as a patient with hepatitis B, the discrimination, the inequity of not having access to treatment, as a mono-infected patient with hepatitis B in low-middle income countries. So it is a great challenge for all of us to really wake up from our slumber if we've been sleeping, that as a community, we need one united, strong voice for hepatitis, especially for hepatitis B. And I'm glad that the World Hepatitis Alliance have a strong partner in Hepatitis B Foundation and Hep B United to push, to try to move the needle on hepatitis awareness. And I'm glad to have also great leaders that have spoken here. And we have Professor Lacy from WHO, which we can always rely on to really help us to drive some of this from the global stage. So I'd like to really say thank you to all people everybody that has joined this wonderful 1 hour discussion. And it is my hope that this has really contributed to raise awareness about the unmet needs in hepatitis elimination. Ambitious goals, but it's still a very long way towards elimination of hepatitis. And one way to go is to increase awareness, hold our governments accountable, and do the needful as a community group. So on behalf of the World Hepatitis Alliance and all the panel, I would like to say thank you for being part of this. And we stay connected and we stay together as one united community to fight and eliminate hepatitis. Thank you very much.
Thank you, Danjuma, for your remarks. I'm pulling up our contact information for folks that are still on. If you have any additional questions, please feel free to contact the World Hepatitis Alliance or the Hepatitis B Foundation with our contact information. We hope that you found the information and perspectives we heard today valuable. Please do feel free to reach out, and please do fill out the evaluation as you exit the survey. We would love to get some feedback and also to hear from you on other topics that would be interesting to hear related to hepatitis B. Thank you so much, Dr. Lacy, Dr. Sue Wong, Robert Wong, Chris, for joining us so late in the evening, and Danjuma as well. And thank you for the partnership with the World Hepatitis Alliance, and everyone for joining. I know that it's very early and very late in many parts of the world, so we appreciate you. And I hope everyone has a wonderful week ahead. Thank you so much.
Yeah.
Good night.
Thanks.
Thank you. Bye-bye.
Bye.
Bye.